So the next speaker is Ian Alexander from Sydney's Children's Hospital Network. His talk is AAV vectors in the liver.
Do we just progress? Bring my talk up now. It's not coming through. Could we bring my talk up, please? Here we go. Look, I'd too like to thank the organisers for inviting me to speak in this education session and share my passion for liver-targeted gene therapy. Like the other two speakers, Shannon and Miguel, I'm very pleased to see the good turnout, particularly on a Saturday morning after the reception. I thought many of you might also be off watching the royal wedding, so it's rather good that you're all here. So my only disclosure is that I hold a small amount of equity in Gyroscope Therapeutics, which is an AVI company, so very little to do with the liver. And given that this is an education session, what I wanted to try and achieve during my presentation was really address the question, if you're somebody who's thinking about moving into AAV in the liver, what would be the things that you would need to know so that you didn't fall into many of the pitfalls that those of us already in this field have fallen into. So I wanted to give a little bit of context with the explosion of interest in AAV in the liver, touch on the therapeutic successes, a little bit of background about AAV that's relevant to the liver, talk a little bit about liver biology and therapeutic promise, and then take a current success, haemophilia B, and contrast it with another disease that people are going after, including myself, OTC, and look at the fundamental different challenges imposed by the disease, and then distill from that some take-home messages. So basically, as everybody would appreciate that from this meeting, there's been an absolute explosion in interest in AAV, and the number of publications in the field is just rising linearly, and you can see that in the red line there. And the number of clinical trials is also going up. And you can see that there's been a particular surge since 2011. And we're now seeing that there's about 30 AAV gene therapy trials being initiated a year. And as a proportion of all trials, AAV is becoming a progressively bigger proportion. So to date, there's been over 200 clinical trials for AAV across all indications, and about 15% of those have been in the liver. The liver is quite a prominent target, and I think this session has really picked the eyes out of key targets. The eye and the CNS and the liver are great targets for AAV. So I went to the Wiley website that documents clinical trials worldwide, and I was able to find these 8 different indications that are in the clinic AAV targeting the human liver. And this accounts for just under 30 clinical trials, and most of the activity has been in haemophilia B and alpha-1 antitrypsin, and a little bit in haemophilia A, and then a small amount in all the others. But these diseases represent a very big range of challenges for the technology. And as I said, a bit later in the talk, I'll contrast haemophilia B with OTC, which is a urea cycle defect. So that surge in interest that I mentioned from 2011, I think maps to publication of success in the human liver for haemophilia B. And that's this initial paper from Amit Nathwani and Andrew Davidoff in New England Journal of Medicine back in 2011, and then follow-up looking at long-term safety and efficacy in 2014. And I think successes in other organs is driving this as well. But certainly for the liver and the interest in the liver, I think these are very important papers. But the question would be, well, what does this tell us about the trajectory of liver-targeted gene therapy? Does this mean that it's pretty much solved? And of course the answer is no. So I would argue that these are very exciting papers, very important progress, but haemophilia B is low-hanging fruit. And in fact, because this is a secreted protein, factor 9 deficiency in haemophilia B, if you drive your transgene with a very active promoter, you can get therapeutic benefit by transducing perhaps as low as 1% of the hepatic mass. Now, the truth is, for many other diseases, that simply wouldn't cut the mustard. So one of my pet issues in the whole gene therapy field is this issue of accurately approximating the technology you have at hand with the target disease that you're going after. And so this Venn diagram attempts to capture that. So I've got the gene delivery technology, AAV, gene addition and genome editing and target disease. And you can see that there's only a modest area of overlap. And haemophilia B fits in that area. But many of the diseases that we would like to go after, and in fact I believe some of the ones that people are already going after, are a little beyond the reach of contemporary AAV technology. It doesn't mean they won't fall within the reach, but you've got to have an understanding of the reach of the technology. And part of the challenge, I think, in the field is most of us fall into one or two camps. We're either the tool makers making the vector systems, or we're the tool users. We're using them on disease of our own interest. And really you've got to have a handle on both those parts of the equation to have successful applications. If you go after something that's beyond the technology at hand, then you're going to fail. So you might come to the field with a particular disease of interest and the technology might be ready. So you've either got to be patient and wait for the technology to develop, or perhaps participate in its evolution by, for example, doing capsid engineering, and we've heard a bit about that already this morning. So I do want to say a little bit about AAV, but given that this is the final day of the meeting, most of you will be absolutely bombed on AAV by now and know virtually everything about it. But the prototypic AAV from which vectors have been developed is AAV2, which is endemic in the human population. In some parts of the world, up to 80% of people have been exposed, and in this audience it's probably between 50 and 70%. And we've recently done studies in the human liver, and we still don't have completely solid data, but we're finding that virtually everybody who's seropositive actually has wild-type AAV provirus in the liver. So most of us sitting here with wild-type AAV in the liver. We haven't had gene therapy, we've just had natural infection. And that is teaching us things about risk, which I don't have time to go into today. The other thing we've learned is that wild-type AAV2, that the liver is an organ that's essential for the AAV life cycle. And again, I won't present the reasons for that, but this virus and the liver have an intimate evolutionary relationship. The other consequence of these viruses, or this particular virus and closely related variants being endemic, is that the seropositivity and the cross-reactivity between capsids and the potential for that to preclude people from participation in clinical trials. So this is really a bit redundant given the point of this meeting, but I did want to say that, so we all know that you can make vectors simply by retaining the AAV ITRs, which are the 145 nucleotide bookends, and inserting your transgene of interest. And because AAV is a single-stranded virus, you can also use it for genome editing, and I'll touch on that in a moment. But what I will say, and this isn't working for me, but just inside the ITR of wild-type AAV is a liver-specific promoter enhancer element. And in some lineages of vectors that people in this room would be using for their work, there are small parts of the wild-type genome retained, and those elements can give your vectors liver-specific transcriptional activity. And so you should double-check that that's not the case with your system. So we heard a little bit about pseudoserotyping from Shannon, and this is my simplified rendition, but I do want to make some serious points. A very important event in the evolution of AAV vectors was the discovery that you could cross-dress the wild-type or the recombinant AAV genome with capsids from other serotypes. And what's really important about this is, apart from conferring different biology and target tissue tropism and different seroreactivity, is that it's very hard to predict the transduction performance of these capsids. And so what you find in a preclinical mouse model or a preclinical primate model is not necessarily predictive of what you'll find in human models. And this is one of the big challenges of the field. We can have lovely preclinical data, but we're not necessarily sure that our capsids are going to work when they get into the clinic. So just to quickly show you, and this is quite old data, if you take a mouse and you take a recombinant AAV2 vector with a type 6 capsid and you give it intravenously, you can transduce essentially every skeletal muscle fibre in that mouse. Very impressive result. But what's particularly interesting is that same capsid, AAV6, is the one that people are using for hematopoietic gene transfer in the human population. And these things are just discovered empirically. They're not easy to predict. And if you take the same mouse and you dress your recombinant viral genome with an AAV8 capsid and you shoot that into a mouse, you get massively efficient transduction of the mouse liver. So this is GFP, and you can see at a very modest vector dose, we can transduce every single hepatocyte in the mouse liver. And it's this type of result that took AAV8 on its journey to the clinic, and that was the capsid used in those New England Journal of Medicine papers, and it was successful by virtue of the fact that you don't need high-level gene transfer for success. And what I was alluding to there is that the AAV8 capsid, and this is still suffering a little bit of debate, is nothing like as efficient in the human liver as it is in the mouse liver. And it doesn't have the legs to go after many of the more challenging phenotypes, or at least that's my point of view. So it's worth also just quickly reviewing the transduction pathway of AAV, but only for to make a few very minor but salient points. And so we know that AAV vectors, depending on the capsid, interact with particular cell surface proteoglycans. They're internalised, traffic through the endozyme compartment and reach the nucleus where they uncoat. And then in the nuclear compartment, that genome can actually become double-stranded transcriptionally active episome, or it can remain single-stranded and be a template for participation in homologous recombination, or a small proportion undergo integration. And you'll hear people saying AAV doesn't integrate. Well, that's simply not true. It integrates quite inefficiently, and it's not an obligate part of the virus's life cycle, but you do get integration events, and I'll illustrate that in a moment. And the reason I emphasise the single-stranded DNA, because it's a single-stranded viral genome, is that that genome can participate in homologous recombination. And David Russell, who I was fortunate to postdoc with, was the guy that pioneered the use of AAV as a template for homologous recombination. And most of the genome editing work you'll see in vivo now exploits AAV, not only to carry CRISPR-Cas9 machinery, but also to provide templates for homologous recombination. And you can do, even without CRISPR-Cas9, you can do all base substitutions, small deletions, and large insertions, and you can do that in the liver, and this is why I touch on it. So, forgive my paediatric nature, but so we've got 50 years under our belt since AAV was discovered, and we have this fabulous modular toolkit that can do transgene expression and genome editing. And this toolkit, you have to know the reach of the toolkit, but the toolkit's also evolving very quickly, and so its reach is improving dramatically. So I think it's a fabulously exciting system. So given that I talked about the tool users and the tool makers, I did want to talk a little bit about the liver now, which is the target obviously here. The liver is the second biggest organ in the body behind the skin, and it's immensely functional, immensely complex functionally. So it's involved in intermediary metabolism, bile acid synthesis, storage functions, regulation, biosynthetic functions, and detoxification. And then over above that, in terms of all of the diseases that are involved in those functions are potential targets for gene therapy. The liver is also a target for infectious disease and viral infection. And so there's possibilities in the liver going after viral infection. There's also possibilities of going after diseases like diabetes by regulated expression of insulin from the liver, or diseases like NASH, which we see, or metabolic syndrome, for example. And the other possibility is using the liver as a biofactory to ectopically express proteins at high level, or to supraphysiologically express proteins that are already expressed by the liver. So it's a fabulously attractive target. And it's also important to understand that not all the functions of the liver are performed by hepatocytes, and yet most of the work that we talk about and everything I'll talk about, we're going after the hepatocyte and not the many other cell types in the liver. So now I want to tell you a little bit about some of the interesting biology of the liver that's germane to gene therapy. And one is this tremendous capacity for regeneration and repopulation. And I don't know how many of you know your Greek mythology, but there was a guy called, well, he was a Greek titan called Prometheus, who upset Zeus by sharing the secret of fire and metalwork with mankind. And as punishment, he was tied or chained to a mountain, and by day an eagle would come and chew on his liver, and by night his liver would grow back. So the ancient Greeks had this appreciation that the liver had regenerative capacity. And we actually know from an experiment of nature in a disease called tyrosinemia type 1, which is a disease where there's metabolites that are hepatotoxic. If you get a revertant event, you can actually get a nodule of perfectly healthy hepatocytes growing from a single hepatocyte, and this nodule could contain tens of thousands or millions of cells. So the human liver has this capacity, and this is another thing that has potential exploitation in the human liver. It's got a very interesting vasculature. I won't labour this point. It's got two blood supplies, the hepatic artery and the portal vein. The functional unit in the liver is the hepatic lobule. And an important point is that the liver only 2.5% of your body's mass, but it receives about 25% of your cardiac output. So when you give vector intravenously, a lot of it's going to circulate to the liver. And another thing that you need to appreciate about the liver, I just showed you a hepatic lobule, but the metabolic functions of the liver are zonated across the lobule. So blood's arriving at the periphery and the hepatic artery, from the hepatic artery and portal vein, and flowing towards the central vein, and it passes cells with different metabolic capacities. So out near the edge, you've got gluconeogenesis, ureagenesis, and oxidative metabolism, and then towards the centre, glycolysis, lipogenesis, and xenobiotic metabolism. And so there's even issues as to where your vector might go within the hepatic lobule. And the other thing that's very important is that the vascular endothelium in the liver is fenestrated. So these are holes that are up to 140 nanometres across. AAV is only 25 nanometres. So 4 or 5 AAV particles can walk through these holes directly onto the surface of the hepatocyte holding hands. And if you consider that 25% of the cardiac output's going there and the liver's directly exposed to the circulation, you can understand why a lot of your vector, if there's any liver trophism at all, gets mopped up by the liver. So I just wanted to come back to these iconic papers and just further explore this issue of me arguing that this is low-hanging fruit. So I said that you can achieve this with 1 to 3% activity, 1 to 3% of transduction of hepatocytes. We don't actually know because nobody's done a biopsy and looked, but this is with AAV-28. So this is the capsids that's gangbusters in the mouse liver. The other thing to remember is factor VIII is a secreted protein, so this is a non-cell autonomous disease, and this is adult patients. Now I'm interested, for example, in treating urea cycle defects, and you might have seen in that list of clinical indications of trials that were already happening was ornithine transcarbamylase deficiency. There's a trial underway for adults. So this is a very nasty group of diseases where children are born well, but once they're flying solo and don't have the mother's placenta dialysing them, they develop hyperammonemia and can be dead within a few days. And the urea cycle is a series of enzymes in the liver that converts ammonia, which is highly neurotoxic, to urea. Long and the short is these kids need liver transplantation with the severe form, and that's obviously a very challenging thing, and lifelong immunosuppression, and it's a disease that's crying out for therapy. But the question is, well, what level of gene transfer would you need to cure this disease? Well, again, nature's done an experiment. OTC is X-linked. So female carriers actually have a chimeric liver. Depending on whether the mutant allele or the healthy allele, OTC allele, is inactivated, and this occurs very early during liver development. And so we have females who are obligate heterozygotes for OTC who have skewed inactivation, where they've inactivated mostly their healthy allele leaving their mutant allele active. So you can see here, this is staining for OTC. In one panel, that's a healthy control female. Every hepatocyte staining for OTC. On the other side is an obligate carrier, and she's got a subset of hepatocytes expressing and a subset that don't. So that's a model for gene therapy. And we know that when ladies, skew their down to about 15 or 20% physiological, they can develop metabolic features of the disease. And so we know this is a disease that's going to have a high threshold. We're not going to get away with 1% transduction. We have to do much better. So that's what I say here. We're looking at perhaps 1% for haemophilia B, 15 to 20% for urea cycle defects. So touching on the story that's already been developed in this session this morning, people are out looking for novel capsids, and they can be isolated from nature or they can be generated by capsid engineering. And we're looking for highly hepatotrophic capsids with differing seroreactivity, such that we could have most people able to participate in a trial irrespective of what their background seroreactivity was. So this is just a sample of 2 native capsids, AAV2 and 8, both of which have been to the clinic, and 2 engineered capsids, one of which is in the clinic for Sparks haemophilia A trial. And this is in the FRG mouse. So this is a preclinical model where you've got primary human hepatocytes growing in the mouse liver. And so we use this model to try and predict the tropism when these viruses get into human trials. But this model's also been used to select AAV libraries that have been engineered to find the ones that go into primary human hepatocytes. And you can see AAV2 and AAV8, at least in this model, the readout is very low. 3 to 5% of human hepatocytes transduced if you're lucky. But these new engineered capsids, LK03, you can hit 40% of primary human hepatocytes. That's a log higher than AAV8. And there was one published, and we've collaborated with Mark Kay on this. I should say that these have come out of his lab with our help in the FRG mouse. There's a new one called NP59 published in Molecular Therapy earlier this year, and in that model we can get 98% of human hepatocytes. So you imagine if you could take those to the clinic, and if this mouse is predictive of clinical performance, the increased reach of the technology. Now the other thing I want to touch on, and this really reflects the fact that I'm a clinician scientist and a paediatrician, so I'm interested in the developing liver. Blow all you adults. So the problem with the paediatric liver is it's growing. And what we've shown in neonatal mice is you can inject a newborn mouse with AAV and very quickly you lose episomal expression. You get some ongoing expression, as you can see across the top panels here, as a function of time through vector integration. And so we can push this and get up to 10% integration, and that may be enough for some diseases, but we've lost episome. And you can see it's much more stable in the adult mouse. And Jim Wilson's group's done similar work in the infant macaque and shown that this phenomena occurs there. And we believe this is going to happen in the human liver, but we don't know at what pace. Now I just want to touch on the mechanism underlying this, because you keep hearing people say it's dilution. So we've done a study here, and I won't go through every panel just for the sake of time, but if you look at the southern blot here, this is a HERT prep, and this is 1 week apart. And you can see on the one side, this is 1 week post-injection, you can see input single-stranded DNA, and you can see double-stranded transcriptionally active episomes. 1 week later, they're nearly all gone. That's a 60-fold reduction in 1 week and 1 liver doubling. So if you say that the increase in liver mass is a surrogate for hepatocellular replication, 1 liver doubling would not give you a 60-fold reduction. So there's almost certainly dilution and active clearance. Now, of course, a mouse can go through 5 doublings, 32-fold increase in liver mass in 6 weeks. Now, we humans don't do that. And so this is actually a human liver weight from an old pathology textbook. And the first liver doubling in a human takes place at about 4 to 6 months. The second liver doubling isn't until you're about 2 years old, and the third liver doubling is about 11 years of age. So, what a mouse can do in a few weeks, we take a decade to do. So the human liver is going more slowly, but if one round of hepatocellular replication can clear episome, one of our challenges in the paediatric age range may be episome clearance, and that could be problematic for diseases where we need a high level of transduction, even if we've got very potent capsids. So possible approaches to the growing liver: you could delay a delivery until the liver slows in growth. You could try redelivery, but there's challenges there because of seroreactivity and antibody responses. You could use some other systems that people like ourselves and others developed, where you can transpose cassettes out of AAV using transposon technology into the hepatocyte genome before the episomes are cleared. You can go in and edit the genome, so these are heritable changes to the hepatocytes. Or, and this is something that Marcus Grompe has championed, and you may have seen his poster and talks, but you can selectively expand hepatocytes, a la the story with Prometheus. So this is just an example of how efficient the piggyback transposon system is. And you can see there with the diagram, if you just go in with a vector that's got the transposable elements but not the transposase, and you go into a neonatal mouse, you can see by the time the mouse is 4 weeks old, there's very little GFP positivity left. If you throw in a second AAV that carries a transposase and you transpose the cassette into the genome before episome's cleared, you can see that you get massive retention of GFP positivity. So this may not be ready for the clinic, great tool if you want to do mouse studies, but it shows the type of things that may be possible. The other thing, we and others are obviously doing AAV-mediated HDR in the liver, and we're doing this in both the mouse and in the FRG mouse in primary human hepatocytes. And we've transposed, using that system I just talked about, a human OTC locus into the mouse liver, and then developed guide strands and HDR reagents on them, and then taken them across into patient-derived primary human hepatocytes in the FRG mouse, and look to see whether we can do homologous recombination. We've got a talk coming up from our PhD student in one of the upcoming sessions where we show that yes, we can do that. So that's very important. And you'll notice that the mouse work and the human work, we use fundamentally different capsids. And you'll also notice that for this editing work, we use NP59. So this is the one that can hit 98% of hepatocytes in that model. So, using the right tools gives you the chance of having success. Here's an example of successful expansion of hepatocytes. So you imagine that you do your primary gene transfer and maybe you do gene editing and you haven't got enough hepatocytes to get to a therapeutic threshold. If you could link the editing event with a selection event, then you could selectively expand those cells. And again, Marcus has been the pioneer in this area and developed a system that's combined genetic and pharmacological, where you can render a wild-type mouse or potentially a human, you can give them tyrosinemia type 1 pharmacologically, and then your vector carries an enzyme that blocks the tyrosine, or it carries an shRNA that takes out an enzyme in the proximal tyrosine catabolic pathway, giving the cells that you've modified a selective growth advantage. And here's an example in a wild-type mouse that you can actually do it using that Serpobar system. And Marcus has moved on to using acetaminophen and manipulation of acetaminophen metabolism. So this is another exciting area for the future in the liver. And the last point I want to make, because I'm running out of time, is you need to be mindful of the impact of liver pathology. So we've done work in a mouse model of primary intrahepatic cholestasis, type 3, and these mice develop liver fibrosis and inflammation as a function of time. And you can see here that if we delay delivery beyond the neonatal period, we see progressive reduction in transduction performance. So there's a lot of conditions, by the time there's liver fibrosis or other problems in the liver, that's going to dramatically affect the way your vector works. So these are all fundamentally important considerations, and I've really taken you on a bit of a romp across all of those. The last thing I want to touch on is vector safety, and I don't want to make too much of this. I think the AAV vectors in the liver have a good safety profile, but we do need to be aware that there are data out there from mice showing that you can get AAV integration events driving insertional mutagenesis and HCC. And it's plausible that that could happen in humans, and there's a recent paper showing that wild-type AAV is possibly linked to rare HCC in the human liver. So I'm not saying that to say don't go after the liver with AAV. What I am saying is we need to be mindful of risk-benefit, and I wouldn't be going after conditions that could be treated very simply. I'd certainly be going after conditions that are life-threatening and require liver transplantation. So it's all about risk-benefit. So that's the end. A few take-home messages. I think the liver is an immensely promising target. I think if you're interested in going after the liver, stop and make sure you understand your disease very well and the technology that is available, and ask yourself, is your disease within reach? If it's not, you can be sure that the AAV toolkit's going to keep evolving, and it may soon be within reach. You should consider the impact of hepatocellular replication and liver pathology, and you should be mindful of the risk of insertional mutagenesis. So I'm going to leave it there. Thank you for your attention, and just thank my team. I mean, I presented a little bit of our work, but I was quite generic, and I've got some stellar international collaborators, mostly in the US and UK, and Mark Kay, Marcus Grompe, Dave Russell, Rob Coaten, and colleagues in London, Paul Gisson and Adrian Thrasher, supporting some of our clinical ambitions in the paediatric liver. So I'll leave it there and take questions if there's time. Thanks.
Okay, I think with that, thank you for your
Sorry,
time.
I ran over a little. Yeah.
Yeah, great.
Okay.
Tomorrow.